Hi everyone, my name is Cecilia, and tonight Elise and I are going to present physiological and social support theories for patients with chronic heart failure. And this presentation is a requirement for Nursing 701, Theoretical Foundations of Advanced Nursing Practice, under the guidance of Dr. Ellen Szymanski. Chronic heart failure is a national health crisis. According to the Center for Disease Control and Prevention, heart failure affects at least 5.7 million Americans. As such, advanced practice nurses see patients with heart failure in many different settings. This could be your primary care clinics, cardiology offices, heart failure clinics, hospitals, and hospice care. The cost to the U.S. economy is astronomical at about $30.7 billion per year. But despite significant efforts by healthcare systems across the country, readmission rates remain high and mortality rate remains unchanged in the last 15 years at 50%. Sister Callista Roy first published her model in 1970. She developed the basic concepts of her model while as a graduate student at the University of California. Since that time, Sister Callista Roy published many books and articles that refined the model. The Roy adaptation model is one of the most widely used frameworks in nursing practice today. An overview of the Roy adaptation model. It is a very large nursing theory that incorporates many different components. First, Roy believes that humans are holistic beings that are in constant interaction with their environment. Roy categorized environment stimuli in one of three categories. Focal stimuli is a stimuli that is in the forefront and captures the person's attention immediately. Contextual stimuli are all the other components that are related to the focal stimuli, and residual stimuli are factors whose effects are unclear in a situation. According to Sister Roy, a person adapts through at least one, if not both, coping processes. The regulator process is a person's physiological coping mechanism. The cognator subsystem is the person's mental coping mechanism. So essentially, the regulator and the cognator subsystems apply to the individual. The stabilizer and innovator processes are similar concepts to the regulator and cognator subsystems, but apply to the same groups. Finally, Roy describes four modes of adaptation, and that would be your physiologic or physical, self-concept or group identity, role function, and interdependence. But for the purpose of this discussion, we will focus on the physiological adaptations of a patient with chronic heart failure. If you can remember your pathophysiology, we discussed and you've learned about the Starling's curve. As the heart fails, which means there is a decrease in stroke volume, as the heart can't pump out as much blood with each heartbeat, the heart rate will go up to help maintain cardiac output. This is one adaptation, and Roy would call this a compensatory process. The kidneys will sense that they're getting less blood flow due to a decrease in cardiac output, and they will start to hold onto fluid. So this increases preload as well as cause vasoconstriction through the renin-angiotensin-aldosterone system. Now, this only works for short term, and as you may recall, there is a peak to Starling's curve. So at some point, cardiac output can be maintained or preload becomes too high as the person decompensates. The physiologic adaptations fail. Thus, medicine has developed therapies to assist the body's intrinsic adaptation. And according to Roy's model, a system that does not adequately meet the environmental challenge is a compromised system. Physiologic adaptations after neurohumoral activation in heart failure. Now, it seems a lot of information on here and may seem a little complicated, but we're going to break it down. So, In here, when neurohumoral systems are activated in heart failure, there are several physiologic adaptations. And remember, we're focusing on the physiologic adaptation here. Now, these can be categorized as functional and structural modifications. So functional may mean increased inotropy, and that means contraction, increased heart rate, vasoconstriction, salt and water retention. On the other hand, for structural modifications, what happens to the heart? Hypertrophy, increased non-muscular tissue, increased expression of adult cardiac genes, which both of them lead into increased energy demand, altered loading conditions, altered vascular and diastolic properties, and pro-arrhythmic mogenic effect. So what are the neurohormonal adaptations in heart failure? So first we have the RAS, or the renin-angiotensin-aldosterone system. Could be second, sympathetic nervous system. Third, antidiuretic hormones. Fourth, it could be myocardial adrenergic receptors. Fifth, it could be ACE gene polymorphism. Sixth, endothelin. Seven, atrial and brain natriuretic peptides. Or eight, nitric oxide. So these are what could possibly be the neurohormonal adaptations, but they're not limited to this. ACE inhibitors changing adaptation. So essentially decreased blood flow to the kidneys caused by decreased output in heart failure causes the release of angiotensinogen. So if you remember in your pathophysiology class again, you know that angiotensinogen converts to angiotensin 1 and then using that angiotensin converting enzyme to angiotensin 2, which is a potent vasoconstrictor. So as you see on the chart, there are several medication classes that inhibit this adaptation process. Blockers. Beta blockers changing adaptation. And again, we're focusing on the physiological adaptation. So the sympathetic nervous system is the other system that initially helps a person adapt to their failing heart, but eventually will fail as well. On the short term, activation of the sympathetic nervous system, such as your adrenaline, epinephrine, and other catecholamines, increase heart rate, contractility, and thus cardiac output. But long term, the heart starts to hypertrophy. It is a muscle that is already weak and is now being asked to work even harder. Thus, the muscle tries to compensate by getting bigger. It's just like your arm muscle if you work it harder. The hypertrophy, however, leads to increased weakness and further loss of cardiac output. Beta blocker inhibit the sympathetic nervous system, and they have been shown to reduce both morbidity and mortality. But as nurses, we know that just treating the physical aspects of a patient is not treating the whole person. So holistic care means treating the psychological as well as the social components of chronic illness like heart failure. Therefore, social support theory is one middle range theory that can be applied by advanced practice nurses to provide a holistic approach for each patient. So social support theory is a middle range theory that addresses structure and interaction in relationships. It impacts health status, health behavior, and the use of health services. There are many positive consequences of social support, including health promoting behaviors, self-efficacy, coping, sense of well-being, self-worth, and of course, you decrease anxiety and depression. It is considered a protective factor that can result in reduced mortality, disease, and disability. So in the case of our CHF patients, social support interventions can provide effective means to maintain or improve their health status. Historical background of social support theory. So in the early 70s, one of the earliest social support theories named Castle was the pioneer in introducing the term social support. Based on the study of animal behavior, he theorized that strengthening social support could possibly improve the health of humans. So there were these two theories, which are called the buffer theory and the attachment theory. So both have been the basis for vital research on the close relationship of social support and health. Buffer theory suggests that social support shields people from life stressors, and then the attachment theory forwards the idea that the ability to form socially supportive relationships is connected to attachments formed in childhood. Towards the mid-1970s to early 1980s, social support was described more in concrete terms, such as interaction, person, or relationship. So let's talk about how social support can be applied in real research theories that we research discussions. So in this article, we chose living as a family in the midst of chronic illness. So the aim of the study was to shed light on the meaning of lived experience of living as a family in the midst of chronic illness. And we can all probably appreciate the notion that chronic illness implies a change for both the individual and the family. So in this change situation, all family members seem to benefit from sharing experiences and receiving support. The phenomenon can be described as having a constant motivation towards well-being. So the results included 2 themes and 5 sub-themes. The first theme was co-creating a context for living with illness, with the sub-themes of 1, learning to live with the expressions of illness, 2, communicating the illness within and outside the family, and then we have co-creating alternative ways for everyday life with the sub-themes, adapting to new life rhythm, altering relationships, changing roles and tasks in families. The experience of living with chronic illness creates a shift on how to live life on a daily basis. So research has shown that focusing on spouses show that support and sharing the burden with family members can help to overcome obstacles. In addition, families living with various chronic illnesses showed a common desire to accept and manage the illness, as well as being emotionally supported. They strive to regain their balance in their lives and then to also find creative ways to find solutions together to deal with different stressful situations. So this may even provide opportunities to deepen their relationships with each other. So families also discover a new meaning of their shared life, and sometimes illness brings them closer together. So the study of the family approach describes the process where these families recognize the vulnerability and the reality of chronic illness, and then they try to adapt to the reality and then make choices in relation to their experiences of chronic illness. The next journal article discussion is entitled Defective Support Network, a Major Obstacle to Coping for Patients with Heart Failure, and it's a qualitative study published in 2016. So heart failure imposes great difficulties on the patient's quality of life because of a number of different issues. It has very poor prognosis. There's a high cost of treatment, multiple symptoms, frequent hospitalizations, psychological repercussions, and social and occupational limitations. The chronic nature of heart failure requires the need for support. Yes, we all know that. Social support was described as a coping resource that provides a way against problems associated with chronic diseases. So types of support could include emotional support, which emphasizes love, empathy, and trust. 2, informational support, which gives the knowledge needed for problem solving. 3, instrumental support, which provides goods and services. It's suggested that emotional support is an important mechanism for compliance to a treatment regimen. And most importantly, the prevention of depression. One recurring issue in the study was inadequate family performance, emotionally and physically. Because of the chronic nature of heart failure, patients constantly experience a multitude of symptoms and treatment problems. Clearly, they need a source of emotional support, such as their family. A lack of emotional support may also cause relapse of the adverse symptoms. Then there's also the psychological damage caused by, say, irritable and detached family members, for example. So, say an 82-year-old female patient can say, my daughter looks after me, she's very impatient, and she gets angry very easily. She treats me badly at times, and it always breaks both my heart and my spirit. Since most heart failure patients are the elderly and are unable to take care of themselves, they need the support of family members for care and in performing daily activities. Inadequate family support in physical care could also give a serious obstacle for patients, and across all stages of heart failure, patients need to receive support from different places. And unfortunately, not all of these needs can be met by family. Indeed, the healthcare team and the society in general must be able to give support through education and even regulations and law. This is actually reminiscent of the ecological systems theory that we have just learned about a few weeks ago. For challenges to social support theory, a middle range social support theory development could be improved by further investigating the role of gender, cultural contexts, causality, interactions, and effective social support interventions. So let's talk about gender first. So for example, we have Mexican American pregnant women. This is a certain type of population that actually need specific assessment questions with regards to social support. The dynamics between the family members may be very different from other families. So for example, a Mexican male is expected to provide for his family financially, whereas women are expected to take care of the children and run the home, but in many households, both adults work. But members of an extended family may live close to one another as a way to maintain cultural identity, and then the extended family can also give support in times of healthcare needs. So there will always be some variances between different cultures. Navajo women is another example. So they were given a personal resource inventory evaluation, and basically what this is just a series of questions that are being asked over to the Navajo women, and they figured that the inventory delves into questions that asks about family involvement, coping skills, and so on, but 10 out of the 25 items were not applicable to the Navajo culture. So those 10 items were considered to be too personal. In the Navajo culture, the questions were family problems, and then feelings are not usually discussed with other people. Cultural context. An example for this would be for African Americans. Hamilton and Sandalowski, 2004, discovered that although the broad categories of social support were acceptable, strategies for perceived helpful social support are markedly different from Caucasians. So for example, African Americans perceive distracting activities and simple presence as they consider them as emotional support as opposed to verbal expressions of problems. So just being physically there and basically just giving them distracting activities was enough for them. They consider that as emotional support. Other types of emotional support that were appreciated much more by the African Americans were offers of prayer and other kinds of assistance, such as bringing food to the hospital or maybe even helping with errands, etc. Causality. What exactly does that mean? So it essentially means that one thing causes the other. So it's a direct result of for one event to the other. So for example, increased social support for patients during the initial stages of CHF diagnosis inhibit development of depressive symptoms. Unfortunately, there are only a few descriptive and correlational studies that link social support to positive health outcomes. But the impact on how people search for and receive social support has really not been discussed much as the effects of social support on people needing it. So clearly, causality in social support needs further research. One thought that was suggested by Cohen et al. 2001 for future research is whether people with chronic medical conditions decrease their social support for a number of different reasons, resulting in an imbalance in reciprocity. Another challenge to social support theory is how effective are social support interventions? And really, there are many ways for interventions for social support. It could be face-to-face, it could be a little bit more personal, it could be telephone conversations, social media, of course. Facebook's very popular, Instagram, your Twitter, your Snapchat, or something as a little bit more simple as your internet communication, such as email, Skype, or maybe even doing GoToMeetings. So several platforms in here. But the proliferation of social media and networking is very important. It's a very important issue to discuss. I mean, this is the age that we're living right now. It may be vital to understand the differences in various modes of communication in terms of social support efficacy. So how do these social support interventions actually help our patients who have congestive heart failure? So a comparison may provide some enlightenment in understanding how to deliver beneficial social support interventions. So a summary on social support theory for CHF patients. Social support can be utilized depending on the specific needs of the CHF patients. Second, it should be further discussed in order to understand the implications of this phenomenon. Third, social support should tackle the impact of social support interventions, including the efficacy of social media and networking. And finally, social support is very, very vital to nurses, to nurse practitioners, and health system leaders. Social support is what's going to connect all our congestive heart failure patients that can move them forward and provide them the healing that they need as they move across the trajectory of their disease. This is the end of our presentation. We would like to thank you for listening, and we hope that you have learned something for the theories, application of theories for our congestive heart failure patients. We appreciate your time. Thank you so much.